while we are getting ready and receiving questions, if there are any from the audience, and Eric is getting ready, we'll start with a question for all of the panelists, and we'll ask each of you to answer. And that is, can you tell us your feelings on prophylaxis? In other words, before the stoma starts in the first place. We know that in the literature, the rate of parastomal hernias is at least 40 or 50%, and most of us believe that is a complete underestimate. If you wait long enough, the majority of patients will eventually develop a hernia at the stoma site. So what can we do with prophylaxis, and what are your thoughts on that? Manuel, you want to start, please?
Okay, we should switch the topic of the talk from the repair to prophylaxis, but I think it is a very good topic also and very difficult. We had our group 2 trials regarding prophylaxis with mesh. Of course, I will speak about mesh because it's another types of prophylaxis as you can, as the construction of the stoma, sterilizing the stoma, behind the peritoneum and so on. This is all options, but I prefer to speak about meshes because probably is the best way to try to do a prophylaxis. But, however, we analyze our results. We have this paper now under consideration in a journal, looking for a follow-up more than 5 years, or almost 5 years in our 2 papers about prophylaxis, and another paper from Serra Aracil, our colleague and friend there in Barcelona. And the mesh at the beginning seems to be that works, but after 2 or 3 years doesn't work. So probably we are doing something like, as I said in my presentation, something like palliation rather than prophylaxis in this case, no repair. We can palliate the parastomal hernia. Maybe some patients can benefit from that, depending on the life expectancy regarding, because the majority of them were operated on for cancer. But in our experience, in my opinion, maybe it doesn't work in the long-term follow-up.
So that's personal opinion. So I go to the evidence. So we've created with the European Hernia Society guidelines about 5 years ago, I think, or 6, where at that moment all the trials, randomized trials that were done with prophylaxis were positive. So we had a strong recommendation to place a prophylactic mesh with an end colostomy at the time of creation of the stoma. The thing is that soon after we published our guideline, there were trials that were bigger than the one that were included in the guideline that were negative, like Sweden, Denmark, and a French trial. So we've updated the guideline now recently, and now the recommendation is still there, but it's going to be a weak recommendation that will be published very soon. So it's a pendulum, and indeed there is a thinking that maybe placement of a mesh might only delay the event of a parastomal hernia in many cases and not really prevent it, which is a good thing, certainly in older patients. And also you might anticipate maybe the subsequent parastomal hernias will be smaller and easier to treat. I don't know. That might be possible, but we don't have data on that. Agneta.
One thing that I think is very important, it's the quality of life for the patients. What are the problems with the stomas, sort of? Quite a lot of the patients that have a parastomal hernia, they wouldn't even know it. So we couldn't put everyone in the same basket, sort of, because you really need to see. You know, it's a treatment that fails frequently, and it's difficult to treat it. So you really should have a good indication for these for the recurrences, because these are tough operations, both for the patient and what to do. It's not obvious always.
But so for the prevention, would you be more in favor or would you be more against now, October 2022, for prevention prophylaxis?
Only one answer.
No, I was just checking with Agneta.
I would say I will definitely make a study to put the prophylaxis with a color mesh, because I think these are, and you should use material that is inert to the intestine.
Indeed.
So that I would, if I would do a study,
Yeah, I know.
I would do that now.
Okay, we move to the States. Eric, short opinion on prophylaxis with mesh in parastomal hernia prevention? Do you hear us, Eric? I don't think he hears us. He hears us.
Eric, do you hear us?
Yeah, I can hear you guys.
Okay.
You know, I was going to take a step back and actually just point out that from my perspective, you know, prophylactic mesh is not commonly used around ostomies in the United States. I mean, there are some people who do it, but the majority of people who I meet with a parastomal hernia have a stoma that was just poorly formed the first time around. It's not in the body of the rectus, it's lateral, it's through the semilunar line. You know, maybe they could have been optimized a little bit more before the stoma was actually formed. And so I think the main stuff that I would emphasize is good surgical technique the first time around if you're not going to use mesh. I think mesh can certainly help, but nothing beats putting the stoma in a good location and having it marked appropriately by a good ostomy and wound care nurse.
The one wouldn't exclude the other, to my opinion.
Agree entirely. I think that you can't assume that using mesh is going to offset a poorly placed stoma. How about if I say it that way?
Mm-hmm. Victor here has a comment.
Thank you so much for your excellent presentations. Eric, I would like to ask you, in the name of many surgeons, in my opinion, pushing the mesh outside of the abdominal cavity seems to be the best way. In your experience, do you consider the erosion, the bowel erosion, due to the direct contact between the bowel and the polypropylene mesh, is it a problem? Is it a real problem? How frequent is this complication, if it exists?
Yeah, so I have not personally had that as a complication of a polyparastomal hernia repair. I think the biggest issue is not the area where the bowel and the mesh are flat against one another, but rather the area where the bowel enters the retromuscular pocket. That area where the bowel turns around the edge of the mesh is the same area in an intraperitoneal parastomal hernia repair, a standard laparoscopic sugar baker, where you also get the mesh erosions. It's not the flat part of the mesh that's the problem. And so I think that when you're doing any parastomal hernia repair with the sugar baker mesh configuration, you need to pay particular attention to the area where the bowel turns over the edge of the mesh. That's true regardless of what kind of stoma it is, and that's true regardless of what kind of mesh it is. I've seen biologic mesh erode into the bowel at that location. If it's poorly configured, it'll be a problem.
Correct, and we got your point on the fixation laterally very well. We have two questions again in the room.
In my experience, about 60-65% of the patients refuse the correction of the parastomal hernia. I want to ask you if your experience is the same, and what are the reasons for they refuse the procedure?
Well, I'm a surgeon, so usually if the patient reaches my office, they've already made up their mind that most of the time they come as a referral to have a repair. So I don't have a lot of patients that refuse. You do have a lot of older patients that come to you where you discuss with them how much, because sometimes they send, oh, this parastomal hernia needs treatment, and you discuss with the patient how much does it bother you, is there problems with leakage or things, how much does it impair your quality of life, and then you make a shared decision. But most of them come already with their mindset that they need a repair. On the other hand, if you do not repair an asymptomatic parastomal hernia, if they come in incarcerated, the mortality in the Danish nationwide data was 25%. So 1 out of 4 die if they come in incarcerated. That's another thing to take into the equation that can play a role in your decision.
Agneta?
But the incarcerations are very few, so it's not based on very many stomas, though.
Okay, thank you. We go to Franz Meyer from Salzburg.
Franz Meyer from Austria, Salzburg. Question for Eric Polai and Philipp Moisams. As far as I know, for many patients with a stoma, it's very important to do self-irrigation. I think this would be really a challenge if you perform a polar repair due to the kinking into in the pockets.
No, it's much easier for them.
Really?
Because most of the time with a parastomal hernia, they have difficulty, and many patients with a parastomal hernia stop their self-irrigation. And when you just point out where the lateralized colon is after sugar baker or a poly repair, it's, in my experience, it's easier for the patients. I don't know what Eric's opinion is.
Yeah, so it may take you a time or two to show them and explain to them kind of what the angle is located. But, you know, oftentimes if you have the patient digitize their own stoma, they can actually feel the bend below the level of the muscle, and they understand that's the way the catheter needs to be aimed or positioned.
Okay, thank you.
So thank you all very much. We'll go ahead and move on to our next segment here.